director, and he is always a pleasure to listen to. So please give him your undivided attention. Remember, you can chat to me if you have to leave, and we will also hopefully be posting this within a few days to the MD Roundtable blog inside the PERCOM Courses website. All right, Dr. Frame, it's all yours.
Well, thank you, and I'm sorry that I'm late getting here. My Wi-Fi actually just went poof, and subsequently we had to reset the router and do all the fancy stuff upstairs. So you'll get full credit for this particular session, and since this will be a two-part session, next week we'll cover respiratory emergencies, some cardiac emergencies as well. Now, what I'm going to do for you is go over respiratory emergencies today. This is all that you're going to need to know about respiratory emergencies for the National Registry, and quite frankly, to be functional out in the field as a paramedic. In a pre-hospital setting, you're going to encounter nothing more stressful than having a sick child. Injured children as well tend to be very stressful, especially if they're critically injured. But the child that's going to cause the most stress for everybody is going to be the child that can't breathe. And as the parents watch their child suffocate and slip slowly away from life, you're going to be the only thing standing between that child and the grave. And subsequently, even though respiratory emergencies tend to be fairly simple in its approach, it is stressful in the entire scenario. So not only are you going to have to know the respiratory emergency and just how to handle that 5 or 6 steps, memorize it, run it through your head over and over again, but it's also going to be something that if you just do it stepwise, you're going to find yourself in a great position to save a great many lives. Now, again, the respiratory emergency piece I'm going to do here for the next 6 or 7 slides, and I see that we're creeping up on the end of the program here. We'll cut it off and then we'll pick it up next week at the same time and discuss continued treatment of respiratory emergencies. So all you'll need to know for the National Registry is right here, and here we go. Respiratory emergencies are probably the most common emergency that you're going to run into. Respiratory failure and cardiac arrest follow hand in hand. You'll find that children very rarely go into VFib, VTAC, and such like that. They go right from respiratory emergency to sinus bradycardia to asystole. The children don't do like adults do. They don't start throwing all kinds of weird arrhythmias and such. So one of the first questions that you will encounter in the National Registry exam is a bradyarrhythmia of a 5-year-old and what the next appropriate step is going to be. Or the scenario, and this is letter B, letter A being the 5-year-old, letter B is going to be the neonate that's just born and yet has a heart rate of 60. What's the next appropriate step? Again, it's going to be a very simplified, very stepwise algorithm that you're going to follow in your head, but you're going to move quickly. And then lastly is what happens when the patient is in the arrest phase and how you're going to treat that. So hopefully you're arriving on the scene of this neonate or this 5-year-old or this 10-year-old, which is the third scenario, letter C on the National Registry, which will be a 10-year-old who has a peanut allergy and subsequently has come in contact with some sort of peanut oil and is moving into anaphylaxis and subsequent respiratory distress followed by respiratory arrest. So of the 6 questions that you're going to have on the pediatrics, 3 of the 6 are going to involve respiratory emergencies. 2 are going to involve trauma, and 1 is going to be a pediatric chest pain in the setting of sickle cell anemia. So for the 10 of us or 11 of us that are present here right now, for the next week until we meet again, you'll want to study the sickle cell patient and the chest syndrome. I want you to take that little 2 notes and put it off to the side because that's going to be your homework for the week. It's going to be sickle cell crisis, sickle cell anemia, in the setting of a patient who's complaining of a chest syndrome, not chest pain syndrome, chest syndrome. And next week, what we'll do is we'll come back on and we'll start with sickle cell, and we'll go over that little homework assignment to see what we've done together and if we're able to answer 4 or 5 questions based on that. So again, 3 respiratory emergencies, 2 cardiac emergencies, 2 chest pain scenarios involving a child, one of them being anaphylaxis, and then 1 sickle cell. Sickle cells become a lot more prominent these days, and the treatment is pretty simple, but evaluation of the sickle cell patient is very complex. Again, we'll cover that next week. So what's the first thing you look at when you arrive on the scene of a 5-year-old? 5-year-old has been getting short of breath, difficulty breathing, has been coughing, congested all day today, maybe with or without fever. And subsequently, you're going to assess 4 things real quickly. Number 1 is going to be retractions. You're going to see the neck muscles as the child tripods forward. In a 5-year-old, they'll probably do that. Second, you're going to see if their abdomen is sucking in and out as well. You'll see that especially on thin kids, although a heavier child, a little turkey ball, if you will, one of those little chubby kids, is going to show you a lot of abdominal breathing. When you see that abdomen moving in and out, and you see those neck muscles start to appear, then the next thing you're going to do is look up at the nose, and you're going to see if the nostrils are flaring open. That's nasal flaring. In other words, they flare open. And then lastly, you're going to listen. The louder the sound, the better it's going to be. As the sound becomes more silent, they're either improving tremendously or they're getting ready to die. That grunting, as the airway gets tighter and tighter, the noise becomes less and less. And this is one time where you don't want a child to be very quiet, is when they're having respiratory distress. As you hear respiratory distress in an asthmatic, as you hear the wheezing is very loud. And then as the wheezing gets softer and softer, less and less, and the child becomes more nasal flaring, more abdominal retractions, more intercostal retractions, either in the neck or in between the ribs, your child is getting ready to go into respiratory arrest. And again, and this is something you do have to know for the National Registry, children move from tachycardia to bradycardia to asystole when they become hypoxemic. There is no VFib, VTAC. Very rarely will you ever see that in a child unless they have underlying cardiac issues or if they've overdosed on something. Okay, so this kind of distress situation that you're running into is going to be a child that has been having difficulty breathing throughout the day. Typically, unless it's an allergic reaction and anaphylaxis, you're going to get a history from mom that he's been febrile. He was seen at the pediatrician's office. He's been having coughing and congestion, but tonight it got real bad. And subsequently, as the child became a little bit more lethargic and such, mom became very concerned because he's making all these seal bark noises or all this wheezing noises and such. And she's been told from her pediatrician to make sure that you call EMS 911 right away and get him into an emergency department. So you arrive on the scene, first thing you're going to do, listen to their lungs, pulse rate, and you're going to go back to what we talked about earlier. And this is the 4 steps that you're going to be looking at. 4 assessments: retractions, abdominal breathing, nasal flaring, and if they're grunting. If you know those 4 signs of respiratory distress, you're going to be able to answer all 6 questions on pediatric emergencies on the National Registry. Now, once your patient starts getting tired, once they're really starting to fatigue and such, you're going to actually see the breathing slowing down. Child's eyes are going to go to about half mast. They're going to start getting really lethargic, altered mental status. Now, just before that happens, the child is hyperexcitable. The child is gasping for air. And the parents, of course, are just as stressed out watching their child suffocate. So the first thing that we want to do just before respiratory arrest is you want to assess the 4 items that we just talked about. Let's make sure that you understand those: retractions, abdominal breathing, nasal flaring, and grunting. You're going to be seeing if there's a good position for them to be in. Most children, especially older children, will tripod. One of the questions is going to be about the child who is tripoding. Usually an 8 to 12-year-old male with history of asthma will tripod. You're going to watch for those retractions, and you're going to watch for both nasal flaring and grunting. Now, again, I'm hammering this stuff into you repeatedly because these are the essentials of all 6 questions. They're going to be scenario-based. They're not going to be, geez, what's grunting? Or how can you tell wheezing from absent breath sounds? Okay, that's pretty rudimentary, and right now we're testing you on how you're going to react to scenarios. And you got to understand the RANG, the R-A-N-G. The retractions, abdominal tractions, nasal flaring, and grunting. Okay. Child sitting forward, tripoding, nose up, sniffing position. And you have to know the sniffing position is that they're trying to stretch their neck and they're trying to decrease the amount of resistance from their nose down into their lungs. They'll have their mouth open. They'll be doing a lot of mouth breathing as well. And then when they start to get into looking like a bit of a guppy, if you watch little fish in the aquarium, you see them with their lips guppying out. As soon as you start seeing guppy breathing, as soon as you start seeing the child moving their lips in an effort to get air in, is going to be the time for you to start looking for the following. Number 1, are they pale? Number 2, are they diaphoretic? Number 3, have they developed any what they call circumoral cyanosis? Now, circumoral cyanosis is just that. They get a blue tinge or cyanosis around their lips. Their earlobes are going to look a little blue. Fingertips are going to look a little blue. You're going to check for capillary refill, and it's going to be a greater than 2-second cap refill. Now you know that their periphery is starting to shut down, and things are going to go real bad real quick. So, doing all the basic assessments here, it's going to be real important, this first piece of this lecture. And I apologize once again that it's been shortened because of a Wi-Fi issue, but it's going to be very important that you assess the airway. Stridor, 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 grunting, grunting, grunting. When you get down to the 4th aspect, the grunting or the stridor, you're going to have to listen for high-pitched sounds. You have to hear for rattling, which is stridor. When they cough, especially those of you who do have children, or Phil would know this from working in the emergency departments the way that he did all those years, you're going to hear children are going to get real high-pitched as the vocal cords become more inflamed and the larynx starts to swell to the point where air is going through it like a pipe organ. And it's going to be low-pitched at first, and when it starts getting high-pitched, when they start hitting the high notes, this is the time that you have to say, we got to do something here real quick. So here we go. We're not going to worry so much about foreign bodies. I'll get into that in a subsequent lecture. That's interesting. The 4 pieces that are the 6 pieces that I want you to know is when you get the pulse oximetry on the child, you're going to be assessing them right away. If they got wheezing going, you want to start hitting the epinephrine right away. Sub-Q epinephrine tolerated very well with children, especially if their heart rate's starting to slow down. We don't start getting worried about pediatric heart rates till they hit 200, 220. To be quite frank with you, we're just not worried about it. And an tachycardia in an adult of 120 would be about the equal of a pediatric 220. In other words, it's a little uncomfortable, but it's nothing that's going to cause a heart attack or blow out their heart or cause cardiogenic shock and such. They do quite well with that stretching to the end of Starling's curve. In other words, how much contractility and how much volume can be pumped at any time. So you're right at the cusp there, 200 in a pediatric patient, 220 on a younger pediatric patient. if you recall from adults over 150, they start decreasing their stroke volume because the heart's pumping too fast for the heart to fill up with blood. In children, it's 200 to 220. So you get the epinephrine ready, 0.15 for the little kiddies, 0.3 for the older children and teenagers and such. And then you're going to put them on what they call blow-by oxygen. Now, after pulse oximetry hits, or if you can see the circumaural cyanosis, the earlobes, and the fingertips, which are going to be quick assessments, you're going to start by putting a mask up by them. You're either going to blow the oxygen by them, hold it to the side, or you're going to go ahead and put the mask on the child to at least try and get that pulse oximetry to 100%. Once you get that pulse oximetry to 100%, at least you got a little bit of time. Most of the time, however, the children will not respond very well when they're having this much respiratory distress. So the second step we're going to go to then is a bag valve mask assist. And that's by putting the BVM right on the child. As long as they're not fighting you, and they start taking the oxygen, try to time it with their respiratory rate. So the first one is blow-by oxygen, and the second one is going to be bag valve mask assist. All right, now there's going to come a time where you got to make a choice here. You've already given the epinephrine. You're going to try and start your IV while you're moving the patient to the hospital. It's best to get the blow-by on the children, get mom, get into the ambulance with the baby on mom, and this is going to be pretty uncomfortable, but somehow or another you're going to have to figure out a way to strap yourself in and at the same time stay safe with mom holding the child, preferably on the stretcher. It's up to you at this point to start making preparations for the third and fourth steps here. If you don't feel like you can get an IV in the patient, then the sub-Q epinephrine is going to work well. As the child shuts down the periphery more and more, and as the child's distress gets worse and worse, your effectiveness of the epinephrine is going to be a lot less because the periphery is shutting down. Where's the epinephrine going? In the arms, in the thighs. So for a younger person, you may want to go into the thigh where the blood flow there is going to be just a little bit more than the arms will be, just because of the greater muscle mass there and its proximity to the major vessels coming up into the heart and lungs. If you can get an IV started, these kids need fluids pretty quickly, but if not, do the best you can. If the child starts to go unresponsive, hate to say this, but we got to get the IO. Fluids are going to be very important for these children. So again, bag valve, blow-by oxygen, followed by a bag valve mask, IV epinephrine administration. If you can get the IV, fine. Sub-Q epinephrine, though, at the same time. We got time for IV epinephrine just a little bit later. Right now, that epinephrine sub-Q has to be a major priority, one of your top 3 steps. Okay. Now, the child becomes even more lethargic. Now you're going to drop an NPA or an OPA. Usually in a real young child, it's an OPA, maybe a little bit older child, NPA. But you're going to drop that. Now you're going to take control of the bag valve mask. It's not so much assisting them anymore as it is now you have to bag the patient and take over their respirations for them. Yes, Chris, great question. Pediatric RSI, well, we might as well talk about it now. You put the OPA, NPA in, and you notice that the patient is still real tough to bag, and your patient is starting to brady down a little bit. You've given the epinephrine. This is going to buy you about 2 minutes. Okay, so for the next 2 minutes now, a decision has to be made. If the child's getting that bad, drill for the IO. Once you get the IO, hook up your 0.9 normal saline, start delivering a bolus so that you can get that periphery expanded back again, that capillary refill, and get that volume back up again. And then what we're going to do is consider RSI. Now for children, it's going to be all weight-based stuff. And a lot of times when these children are crashing the way that they are, all you really may have to do is to paralyze them so that you can follow up with the next appropriate step. And that's going to be the last step. That's going to be intubation. So let me ask you good folks now, what does it look like from an intubation standpoint when it comes to RSI in children? Has anybody given it any thought? And just freewheel it out there.
You guys can unmute your microphones if you want to answer the question.
I've done one RSI on a kid, and it was the craziest thing I have ever done in my life, and it was in a hospital setting.
Really? All right, very good. Now, at what point was the child where you had to go to intubation?
Sir, the child was, let me think here, this was 13 years ago.
Okay.
The child was a 5-year-old male who was brought into the hospital by his mother, suffering from an extreme case of respiratory distress, and he was panicking. He didn't really have the period where he was fine, collapsed. He was literally panicking the whole time, and he just did not want to cooperate. The paralyzing was less so about the respiratory and more so about the mental aspects of it.
That's usually what happens, and you also got to deal with the mom as well. But when a child starts getting really hypoxic, it's just like an adult. They're going to act like crazy people. And if you talk to an adult, 2-3 weeks after they've been better and such, you ask them, "What's the last thing you remember?" And the answer is going to be, "I remember sitting on the cart. I remember the paramedics arriving. Then I don't remember anything after that." What's happened is that they become hypoxic. Upper level brain functions shut down. They're gone. They're not going to remember anything. Subsequently, they're just functioning at the brainstem level, trying to keep their heartbeat, trying to keep the respiratory centers alive. Their CO2 is building up and getting worse and worse and worse. If you've got capnography in these patients, in a normal adult asthmatic, you could have capnographies of 60 or 70. What happens at that point? They're CO2 narcotic, and they're essentially self-sedating. They're slipping off into unconsciousness. Children do just about the same thing, except they go into more hypoxic drive with the low O2. Their CO2, which is what you see in mostly adults and such like that, you'll find that children have a same time drop in the oxygen as they do with CO2. So this is kind of away from the test and away from everything else. Put your pencils down for a second, just kind of grasp this whole thing. Is that when kids go down, they go down quick, and you might find them becoming hypoxic and altered mental status faster than you'll see a CO2 retention. So don't get fooled. In an adult, you may wait for a 60, 70, or you may wait for the altered mental status before you etomidate and vecuronium or etomidate and sucks or Versed and sucks, whatever combination you want to use, patient dependent. But for children, you're going to move fast with Versed or etomidate and then go to your non-depolarizers as fast as you can. You can use 30 milligrams of succinylcholine in kids. That's fine too. But for the most part, they do just as well with either one, paralytic, succinylcholine or vecuronium. Adults tend to do a lot better at vecuronium because most adults have heart issues, and the last thing you want on an irritable heart is a depolarizer. But the children, you'll move into the RSA pretty quickly, and that'll be for next week's lecture as well, as we'll discuss the medications and the proper sequence of these medications in order to intubate. But what you should know for right now is, number one, stimulate the child, obviously, if it's a neonatal newborn baby. Second is blow by oxygen. Third is going to be bag valve mask assist. And then is finally going to be bag valve mask control. In other words, you're taking it over. And then lastly, intubate. Now, the objective here in the intubation, the objective on bag valve mask and the non-rebreathers and all the other things that you're using is not so much to reverse CO2. Children tolerate a very high CO2 much, much better than adults do. The objective is to keep the brain alive and subsequently just reverse the hypoxemia, get their pulse oximetry up to 99%, 95%. Is going to be your primary objective before they get into that Brady situation that we're talking about. And remember, once again, on the National Registry, when it comes to respiratory emergencies, that when that patient starts to Brady down, it's time to get serious about what's about to happen, because that kid's going to go from 80 to 70 to 60 to 50 in the time that you're reaching for the tube and getting set up for an intubation. Now, young kids are pretty easy to intubate. You can get them intubated pretty quickly and have one person kind of hold them, but the older child is going to fight you. And it's going to be near impossible to get that glide scope or that video king or even a regular intubation equipment into their mouth and getting them to hold still to drop an ET tube until they finally go into arrest. Once a child goes into cardiac arrest, it's damn near impossible to get them out of it, especially if they go into arrest because of hypoxemia. And you should know this. You need to go prepared into a pediatric emergency a heck of a lot faster and quicker than you do adults. Adults, you can drop an OPA and you can get the patient asleep pretty quickly because the IVs are pretty easier to hit. But with a child, you're going to have to make some very quick decisions very quickly about an IO. Do not wait for the bradycardia. If the bradycardia is already upon you, the IO should be getting into them. At the same time, your paramedic partner is given epinephrine, either 0.15 or 0.3 sub-Q. Buy yourself that 2 minutes of time while one of you is bagging the patient. The other one's got to be drilling. And then we make a decision at that point to use the 1 to 10,000 epi, or if we use atropine to temporize it once again. But subsequently, you're going to need that etomidate, you're going to need that or Versed or ketamine, and you're going to need that paralytic to get this child intubated. All right, so you've got the quick steps. You got the PALS, the Pediatric Advanced Life Support algorithm in front of you. You may have a Braslow tape. Hopefully you do. Hopefully every system does. The 2008 is the most recent, unless somebody knows of a more recent one. And then it's a matter of measuring them and figuring out, do I need atropine at 0.2 milligrams per kilo? Do I need epi at 0.1 milligram per kilo IV push? Should I be using whatever other medication that you need to be using? But the becuronium and Versed tend to be pretty easy, or becuronium and etomidate tend to be pretty easy, 0.3 per kilo, and then becuronium 0.1 per kilo. And all this stuff is on the Braslow tape. So again, for the National Registry, we're going to wrap this up because I apologize I was late. Next week will be the more fulfilling lecture, if you will, as we discuss RSI with these children, and respiratory pharmacological rescue in the children for next week. But for this week, let's just concentrate on RANG, RANG, and you're going to concentrate on epinephrine administration and then the first 5 steps it'll take to stabilize a child. First, by stimulation if a neonate. If it's an older child, it's going to be blow by oxygen, the non-rebreather mask, the epinephrine administration, sub-Q. Then it's going to be bag valve mask assist. And then as they start getting worse, you're going to have to actually take over the respirations with an OPA and PA and do the bag valve mask control. And then finally hit the intubation and make sure these steps go fairly quickly. All right, now, wanted to leave at least a couple minutes for questions. And I got Lene, you got to go. All righty, you take care. We'll see you next week.
Yeah, I think Linnea had to go, and probably Jason has had to go.
Yeah,
Jason,
right.
You're not still here anymore, right? Okay. How about you, Jeff? Do you have any questions? Oh, I hear you now. You're still here?
Yes, I'm heading out now.
Okay. Thank you, Jason. I won't pick your brain. Have a good night.
Thank you, Dr. Frame. Thank you.
You're most welcome.
All right, Tim McKenna, how about you?
Yes, ma'am. I'm still here. I don't have any questions right now. I appreciate your time tonight, both of you.
Yeah, and I appreciate your time. Again, this is one of the first times that I've ever had a Wi-Fi problem, but barring any disasters next week, we'll go over all this again. And then I'll have some sample questions for the National Registry for us to kind of go over to see how respiratory emergencies are treated by the National Registry on the final exam. Other than that, I don't see any other questions here. So let's wrap this up as a short meeting, but you'll get full credit for it.
What night do you want to do this next week, Dr. Frame?
We're going to have to post that because I have,
Okay.
I did not check my schedule because I didn't plan on having one, but I'm going to make room definitely to have one because of the disaster that I suffered tonight.
No worries.
And I'm sorry, guys. I really
That's okay. We all understand. I'm not going to pick anybody else's brain. You guys stuck with us, and I've already posted your credit. Thank you, Dr. Frame.
Thank you. You guys take care. And
Good
thanks
night,
for being
everybody.
patient.
Night, everyone.
I feel horrible about that.